Hello everyone, welcome back to another session in dentistry and more. Today's session is about public health dentistry, that is a question paper discussion. Previously I uploaded one video regarding the same, but it was not in detail one, but this will be a part by part series. We have made it into 6 parts and that will be covering all the chapters and the questions which has been asked in university question papers over the last 7 to 8 years, and we are following the questions of Kerala University of Health Science. So today's session, that is a part 1, will be including the first 3 chapters, that is Peter chapters 1, 2 and 3, that is Introduction to Dentistry, then Public Health and Dental Public Health, and the important chapters Water Purification and Waste Management. So these 5 chapters will be discussed in today's session. So we'll start with the first chapter, that is Introduction to Dentistry. This is not very important chapter, but mostly 2 short notes will be asked from this chapter, that is Dental Council of India and Indian Dental Association. Dentist Act is very rarely asked, but Dentist Act is associated with Dental Council of India, so you must be knowing few things about Dentist Act. So Dentist Act of India, which was which made as a law by the Parliament on 29th March 1948. Like any other law, Dentist Act of India also has many chapters. So Dentist Act has 5 chapters. They are Chapter 1, Introduction, which says about who is a dentist, who is a dental hygienist, who is a mechanic, dental mechanic. Chapter 2 is the most important one, that is Dental Council of India. It alone can ask as a short note. Chapter 3, the State Dental Council. Chapter 4, State Dental Council means the constitution, the roles and duties of State Dental Council, similarly with the DCI. Chapter 4 explains about the registration process, transfer of registration, all those things. And last chapter, miscellaneous, it is about the punishment, the obligations, and a little bit about the ethics of dentists towards the colleagues and society. The most commonly asked question of this chapter is Dental Council of India. Sometimes it will be functions of Dental Council of India, sometimes just Dental Council of India. So you need to write about its responsibilities as a recognition to dental degree, then maintaining a standard of dental education in our country, and they send inspectors to assess the standard of examination for a new college. Let it be a new course, BDS or MTS, they send examiners until the first batch is passing out. Then they decide the experience required for the registration of teaching faculty, and this started on 12th April 1948. That is, Dentist Act came in 29th March 1948. So next year DCA came into existence, that is 12th April 1949. So the election process of DCA, any DCA will be, usually it is 5 years, 10 years. So at a time there will be members from all these categories. So this is how the members of DCA been selected. That is, there will be 1 member from every state, that is State Registry of Part A. Then 1 member from Medical Council of India. 4 members will be selected from the group of deans, principals and vice principals of our country, the dental colleges of our country. Then 1 member from each university, and 6 members nominated by the central government and 1 by the state government. So all these members constitute the Dental Council of India. So functions we already seen, so we need to write about this part and the function part as a short note answer for the question of Dental Council of India. Next question is Indian Dental Association. So Indian Dental Association is not a statutory body, it is for the upliftment of civilization. This is what they meant, and it is basically for the dentist and their activities. The first dental association was started by Dr. R. Ahmed, who is known as father of Indian dentistry. Sorry, one A is missing here. Sorry for that. So he started the Bengal Dental Association as All India Dental Association. First name of IDA or Indian Dental Association was All Indian Dental Association. So it started in 1928 in Bengal. Same person started the first dental college in India, that is Bengal Dental College. So this All India Dental Association changed its name to IDA in 1949. So after that it is known as IDA. So it is having a jumbo committee, that is one president elect, that is the next one who is going to replace this person, and one past president, three vice president and honorary general secretary and assistant, one treasurer, one secretary of CDH and one editor. So totally in our country we have 29 state branch, 7 union territory branch and 450 local branch and 1 defense branch. This number might be changed because many local branches are popping up. So how can we take membership? See, all these things you need to write in Indian Dental Association, a little bit about its history, its head office, its branches and its membership and function. So honorary members are very respected peoples in the field of dentistry. They'll be kept as honorary members. Life members, they will not pay the annual fee. They will pay only one-time fee and they'll become life members. They'll be very senior most members. Annual members, they pay annual fee. Then the direct members, they work at the same place where they are joining in their association. Student members can join IDEA. Affiliate members, they work at different place than their home city, so they will be affiliated to that home branch or vice versa. And functions are like keeping annual conferences at various levels, conducting programs like seminars, lectures, panel discussion. It's not panel discussion, it's panel discussion. And other school dental health checkup or treatment camps, and also publishing monthly journals. I'm not going line by line. You need to just highlight the main points. Okay. Next chapter we have Introduction to Public Health. The commonly asked question is, what is primary health care and what are the principles of primary health care? Primary healthcare, we know, we don't need to write a very detailed definition. If you know a definition, that is well and good. Primary healthcare is nothing but providing health at a very basic level, that is providing health at primary health center or sub-center where the first contact of people comes with the healthcare system. So we have 4 principles of primary healthcare. In public health industry, we get many principles. Don't get confused. We have principles of epidemiology, principles of health education. So there are many principles. So always keep some connection with each principle to that topic, so that you don't write the other answer for this question. So we have 4 principles. The first one is equitable distribution. That is, we need to provide for the needy people. That means if we have lots of hospitals at urban area and very less number of hospital at rural area, that is not equity. Sometimes on a larger scale we can say that total number of hospitals is proportional to the people. That might be an equal distribution, but it is not equitable distribution. Equitable means we should provide for the or as per the need. Okay, so there should be ample amount of health services corresponding to the number of people present. So usually in India what we see is equal distribution or somewhat equal distribution. Total population, doctor population ratio is fine, but we know it is not equitable because in urban area we have 1:5,000 dentist population ratio, that is well under the WHO norms. But what happens is in rural area it is going up to 1:2.5 lakh. So that is not equitable. So we need to have equitable distribution. And for primary healthcare there is always community participation, that is involvement of the community where the health is being provided, like ASHA scheme or other volunteers. They should be actively involved for the primary healthcare. And there should be intersectoral coordination. It is intersectoral coordination. Sorry about this spelling mistake. And intersectoral coordination, there should be a coordinated activity. That is health, administration section or finance section, all should be coordinated. And there should be appropriate technology. The technology should be appropriate for the need of the people. We should not give hi-fi technology for the people who are not able to use it. So it should be based on the need or the felt need of the people. That is the 4 principles. So you can little bit explain about this if it is being asked for a short essay, but mostly it will be short note. If it is asked as a long essay, you need to give a definition also for primary healthcare. So the next question, that is a short note, epidemiological triad. So epidemiological triad, there is nothing but the disease occurrence. Nowadays, the disease occurrence is determined by the interaction of 3 factors, that is agent, host and environment, not just by one single factor. So that is epidemiological triad. You can explain it with some example of any disease. You can start with dental caries. Next question is define public health. Describe in detail about the changing concepts of public health. So public health, you need to give a definition, then changing concepts of public health. So there is another changing concept that is regarding the health, but we are talking about public health. So we have 4 changing concepts. First one is disease control phase, then health promotional phase, social engineering and health for all phase. And it starts from 80-80 to 90-20. There is 40-year period, here also 40-year period, then comes the 2020. Last one is health for all, which starts from 1981 to 2000. So in disease control phase, it was mainly focusing on the physical environment like water supply, sewage disposal, not particularly to control any disease. Whereas health promotional phase is little more advanced, where the health promotional activities like women and child program, nutritional programs, other programs were included. It was mainly implemented through primary health centers and sub-centers, and community development program also was there in health promotional phase. Whereas social engineering phase is in 1960 to 80. So it was mainly the concept of lifestyle diseases and risk factors, because a single risk factor can cause many diseases. Because after the world has recovered from the World War, the lifestyle diseases started emerging to the affluent society, that means developed countries. Now in developing countries also, these lifestyle diseases are on a increasing fashion. So risk factors are the main point of social engineering phase. They were trying to control these risk factors. And lastly, the health for all phase, which was the last one, where the idea was to provide health for everyone, irrespective of the country or irrespective of the economic background of the country. So as we all know, 10 to 20% of the world population in developed countries has access to the health service of any kind, but the majority or the most of the people, 80% of the people, is not having such an access. So that disparity should be removed. That was the aim of health for all phase. Now we have some short note. What is primary health care or the levels of healthcare? So levels of healthcare, we have 3 levels, that is primary, secondary and tertiary. Primary is the first contact through primary health centers and sub-centers. In secondary healthcare, we have more problems will be dealt, that is curative services, surgery, mainly done through district hospital and community health centers. And the last level or tertiary level is the super specialty hospitals and medical colleges, where all the treatment will be done. Next short note is the natural history of disease. So it all comes under concept of causation. So it has 2 phases, pre-pathogenesis and pathogenesis phase. Pre-pathogenesis idea is the disease or the causative organism or the cause which is creating the disease has not entered the person. Okay, but there is interaction is happening with the human and the environment, so, or the agent, host, environment. interaction is about to initiate the disease process. That is a pre-pathogenesis. Pathogenesis not yet happened, but it is likely to happen. Whereas the pathogenesis phase, the entry of disease agent happened in the susceptible host, and the organism multiplies and starts its physiological changes. And there will be incubation period, then the early and late pathogenesis. So that was about the natural history of disease. Then we have germ theory of disease. So germ theory was first one put forward by Robert Koch. The one-to-one relationship, a single organism is causing a disease, but it is in 20th century early period only it was rejected for many reasons, because now we know it is not just single agent causing disease. We have many other theory, web of causation, epidemiological triad, multifactorial causation, and this cannot explain all the lifestyle diseases like hypertension, diabetes, or cardiovascular or cancer. You can explain about KUHS postulates. The 4 postulates are there, so that also you can include to get the good marks, because everybody will be writing all this. So if you put extra points, you will be getting good marks. Iceberg phenomena also once asked for university. So iceberg phenomena is nothing but the clinical cases which will be visible above the water level, and the invisible cases or asymptomatic cases will be undiagnosed cases, or they are the carriers which is below the water line. Okay, so if we take iceberg of dental caries, we know the earliest lesions D1, D2 or subclinical will be under the water line, and the clinically detectable cavities which is limited to enamel, dentin, which is D2 and D3, and pulpal lesions only will be visible. But we do more screening or more screening cams, we can find out this D1 and D2. So that is the importance of screening. So iceberg phenomena is mainly it is associated with lifestyle diseases, because most of the people will be under the water line. I mean the diabetes people or cardiac diseases or hypertensive people, they come to this spot only when they feel symptoms. Now we have the changing concepts of health. Public health we already seen. Changing concepts, we have 4 concepts: biomedical, ecological, psychosocial, and holistic. This is about health, not about public health. Okay, biomedical says health is just absence of disease. This is in term with the germ theory of disease. It is not taking consideration of any other factors like environmental, social, cultural, all other factors being excluded. So it was not at all acceptable concept of health. Sorry. The second one is ecological. So it says that the disease happens due to the imbalance between the human being and environment. Okay. Whereas the psychosocial says the health is always influenced by the other factors like social, cultural, psychological, economic, and political factors. Holistic is more of a combination of all these factors. Next question. It is not very frequently asked, but sometimes it is asked: web of causation and multifactorial causation. So it is all explaining the lifestyle diseases or chronic diseases like web of causation model. The heart disease, sleep apnea can cause, low socioeconomic status can be a risk factor, lack of exercise, poor diet can be uh, risk factor for the low socioeconomic status, and high blood pressure associated with old age, whereas high blood sugar associated with old age can also lead to heart disease. So tobacco smoking can lead to heart disease, high alcohol can lead to heart disease, then depression and stress can induce high alcohol intake for the person. So all these are linked each other, so we just cannot say that one is causing the other one. So that is a causation, web of causation. The multifactorial causation also is similar, like a single disease is not caused by a single organism, like how the germ theory was put forward. This is like multifactorial. There is time factor, there is diet factor, there is host factor, there is bacteria, there is the organism. So all these combinedly producing a disease. So that is about multifactorial causation. Whereas the spectrum of disease, it is just a graphic representation of variation in the manifestation of disease. So disease will be starting as a subclinical infection and reaching to a fatal illness. So it is a sequence of events occur in human host from the subclinical, that is the first contact of this agent, to the ultimate outcome, which can be a death of a person or can be a very fatal one. So next chapter is Introduction to Dental Public Health. So one question which was asked, which is not very important, but it was asked: define dental public health, outline the dental public health problems in India and the national health programs in relation to dental public health problems. So it is not very you cannot write very detailed question answer for this, because there is not much programs related to dental public health problem. Only tobacco control program is there, and cancer is not particularly about oral cancer, it is overall. So you just cannot write a very specific answer for this. Anyway, you need to write the definition, then the dental public health problems what India is facing, like the workforce unequal distribution, there is no concept of primary oral health care, and the internship program is always underutilized, and people always go to over-the-counter medicines for dental pain and other conditions. They have a lack of awareness. And oral health at rural area, they have no access, they have no dental hospitals, dental clinics in those areas. The dentists are reluctant to work in rural area, and research and programs on dental public health is at its very nascent state in India, because we are never a research oriented country, always on a curative basis. So you can explain more about these problems in your own words if the question asked as dental public health problems in India. So some of the national health programs, preventive and promotive healthcare, like Indradhanush program, like tuberculosis control program, AIDS control program, pulse polio, and for non-communicable disease like control of cancer, prevention and control of deafness, mental health programs. So many programs are there. So you can list out few of these, and the miscellaneous like immunization program, Janani Shishu Suraksha Karyakram. So many are there. You can just list out one or two in each category. So the short note asked was difference between public health dentistry and clinical dentistry. So you can list out these 7 or 8 points. Clinical deals with one patient. Here the group of population. Here patient comes to practitioner, where practitioner goes to the patient. Patient can pay for the service. Depends on a big source. Like funding is a big thing in public health dentistry, then service provided will be immediate. If you do a restoration, you can see the changes very fast, but this is focused on prevention, so the changes takes time. Individual practitioner is only concerned about patients suffering from disease, but we public health practitioners takes account not just person but also are not suffering from it. That is, apparently healthy people are also being taken into consideration. So more concern about period of pathogenesis, but public health dentistry focus on pre-pathogenesis, that is, the disease not yet occurred, and the individual practitioner concern about environment is very limited, but the public health professional studies in detail the environmental aspect of the disease. So this is another question, characteristics of public health methods. So these 8 are the characteristics of public health methods, which is given in the Sovereign Peter, like group responsibility, it relies on group efforts, prevention, concept of medical indigence, and the multifactorial concept, the biostatistical method dependence for public health, and they deals with healthy and apparently healthy, that was we were talking about pre-pathogenesis, and adaptation of programs to community culture. So these are the characteristics of public health methods. So what are the duties of public health dentists? So this was another question. So health education and motivation, the treatment to community, oral hygiene measures, and caries preventive measures, community activities, conducting camps and field programs. And these are the tools of dental public health. that is epidemiology, biostatistics, social science, principles of administration, and preventive dentistry. Now we have the important chapter, that is water purification. The commonly asked question is like this: define potable water, describe the methods of purification of water. So the main question which is asked in this chapter is define potable water, describe in detail various methods of purification of water. So potable water is nothing but which is free from pathogenic agents or chemical substances or any odor and color. Mostly we have large scale and small scale purification. Basic steps of water purification is storage, filtration, and disinfection. So storage is basically for the slow sand filter, where the storage will be there for 1 week or 2 weeks, or we can use a natural or artificial reservoir. Filtration, we have two methods: slow sand and rapid sand. Currently used one is rapid sand filter, because slow sand requires a big land area. It is not possible nowadays, and it takes 1 week or 2 weeks for the biological layer to get formed over the sand bed. That is the ripening of the biological layer, that the algae formation over top of the sand bed, that is the Schmutzdecke or the vital layer. Whereas the rapid sand filter mainly focusing on removing all those impurities by the alum or the coagulation process. They add chemicals and do the job very fastly, so that is convenient for the present need. And the last step is this: filtration. First we store it, and in rapid sand there will not be any storage. It is directly coming to the filter and pumping out as a clean water, whereas slow sand filter only actually requires a storage space, because it takes lots of time, because we need to have a formed biological layer of the sand bed. So it takes time, 1 week or 2 weeks for this algae formation. So it acts as a filter. So disinfection is the last step of water purification. That is, we add chlorine to it. So it removes all the bacteria, oxidizes ion, and reduces taste and odors. So the same question been repeatedly asked many times in 2014 also. Question will be a little different, but the answer is same. You need to be very alert. So rapid sand filters actually started in USA. Have two types: gravity, that is Peterson, and pressure type. So these are the steps of rapid sand. First will be coagulation. The alum will be added, so the impurities will be coagulated and sedimented. So sedimentation tank at the bottom, we remove this sedimented coagulated impurities. Will remove it, and after that it will be sent to the filtration tank, where there is filter bed will be present, and the water will be filtered through it, and will add the chlorine and send to the home. We send it out of the water purification plant for the consumption. So advantages of rapid sand filter is very rapid, and we can deal with raw water directly without any storage. So that is the most important, and 40 to 50 times faster, because slow sand filter needs the formation of biological layer. It takes time. And washing of the filter also is easy, because in slow sand filter the filter cleaning is a tedious job, because we need to remove the top layer of a filter bed. By default the filter bed will be very large, so we need more men at work to remove all those filter bed. Always try to write this comparison, because it is more of a compressed points on these two methods. So as I said, slow sand filter requires large area compared to the rapid sand, and the rate of filtration is very different. It is faster here in rapid sand. Sand size is more in rapid sand. The pre-treatment is like coagulation, because we add coagulant alum. Here there is no chemicals in slow sand. Filter cleaning is backwashing. So that is, we are going to see next slide. Scraping is, as I said, we just scrape it off, and we keep the filter bed to form a new biological layer. So that's why it is very laborious, time taking, and operation is like more skill, because there will be addition of coagulant, addition of all these at different intervals. So we need more people for the operation. Removal of color is better at slow sand. Bacteria is better, almost 100 at slow sand. So that was about the rapid and slow sand filter comparison. Next we have small scale water purification. It is done at home, like boiling, chemical disinfection, bleaching powder, chlorine solution, iodine. Wells are cleaned. So all these includes the small scale water purification, mostly which is done at home. Chlorination is the last step of water purification. It is mostly done using chlorine gas or perchlorone or such chlorine tablets or bleaching powder. So sometimes question will be like principles of chlorination. So water should be clear, free from turbid. Chlorine demand is the amount required to destroy the bacteria, oxidize organic matter, and to neutralize the ammonia. So always this is a thumb rule: 0.5 milligram per liter for 1 hour is required for water. Okay, so the sum of chlorine demand of specific water plus this 0.5 constitute the correct dose of chlorine to be added. So we need to first find out the chlorine demand. Okay, that is breakpoint chlorination. Then on top of that we need to add this 0.5 milligram per 1 liter. Okay, so that is how we decide the dose of chlorine. So vital layer is another question we already discussed. That is a formation of this algae slimy layer over the slow sand filter. This is known as heart of slow sand filter because it acts as a filter, because we are not adding any chemical in the slow sand filter. So we're just having this a biological layer which is formed over the top of this sand filter. So this filter will remove or it blocks the particles. Okay, so after a few weeks or days we need to remove this by scraping off. And breakpoint chlorination is nothing but addition of chlorine to water to a point at which the free residual chlorine begin to appear. So that amount we need to calculate. Over that we need to add 0.5 milligram per liter. That will be the dose of chlorine. And backwashing, what we do, the cleaning process in rapid sand filter, because we are just reversing the flow of water. Okay, so usually water comes from here and go through here. So what we do is we reverse the water, or we just pump air. So what happens is the impurities which is present over the top of this water bed will be removed, will be cleared out. Okay, so it will be frequently done in rapid sand filter. So that is backwashing. Okay, so the last chapter of this session is waste management. Mostly it will be short note or short essay will be asked from this chapter. The commonly asked question is composting. Let it be aerobic or anaerobic composting. Basically we have three methods. That is Bangalore method, which is anaerobic, where no oxygen is present, which will be happening inside a trench. Mechanical composting, which is aerobic, which is happening inside a machine. Okay, it will be with the presence of oxygen. So that is mechanical. And vermicomposting, we know the one which we create at home. So composting is process where we use only degradable things to make a humus-like material, that is known as compost. So mostly the byproducts are carbon dioxide, water, and heat. But what happens is when we mix the non-degradable substance like plastic with this, the byproduct is not carbon dioxide. Instead, there will be formation of methane, which causes global warming. Bangalore method or hot fermentation or anaerobic method, which is invented by Indian Council of Agriculture Research at Indian Institute of Science, Bangalore. So it is like trenches are dug, like these trenches will be dug, and there will be layer by layer addition of night soil. Night soil is soil which includes human excreta, and layer of cow dung or organic waste, and layer of refuse. Will be keep on adding it until the top layer is 9 inches thickness, and then this is covered with excavated earth and compacted. After 6 months, this will be opened and it will become a very good manure, and we can use it for agricultural purpose. So there is dimensions for the trench we make. So uh, we should wait it for 4 to 6 months for this waste to become a manure. So this is a Bangalore method, which is anaerobic, but mechanical composting is aerobic, where the materials will be degraded into a big machines and make it to a very smaller components, and you can see this is rotating in the presence of oxygen. So that is why it is aerobic composting. Incineration is nothing but reducing the volume, okay, by burning the waste. So there are three types: single chamber, double chamber, and rotary kiln. So single chamber, where the heat is around 700 to 1000, whereas a double chamber, the material which was burned in the first chamber will be burnt at a higher temperature, 1200 to 1500. So again there will be reduction of volume. Rotary kiln is very expensive, and it has got it is the best method, but it is very expensive, around 50 lakhs. So usually very few institute or few places will be having this rotary kiln. So mostly the double chamber is a convenient one. Then the methods of solid waste disposal, we already seen what is composting, what is incineration. So the first method is dumping, that is just open dumping. It will create lots of problem, nuisance, and the rodents will take, and the problems of smell, odor, and all these problems are there temping. So little bit better thing is control tipping or sand-free landfill. It is like where natural pits are available, or we can dig and deposit, and if we have a sloping terrain, we take a trench, or we create a trench and we add the waste into it and cover it, okay, but we don't segregate the waste. So ultimately this is not a very good method, but it is a better method than the dumping. But what happens is, the byproduct is methane gas. It can create global warming because this methane is not good for environment. So this is categories of biomedical waste. We have 10 categories, and this is very commonly asked question. Category number 1, 2, 3, 4 are anatomic waste, animal waste, microbiology. 4 is waste of and how it is being disposed. Okay. Sometimes this color coding also will be asked. What is the color, where it will be disposed, all the red color, yellow color, and the green one, black one. So all this will be asked as a short note. Okay, so that's all for this session. So I'll be continuing the next session with regard to the general epidemiology, which is the most important chapter in public health dentistry. So this single chapter will be dealt as part 2. So I'll come with the part 2 session next in my next video. So always make sure that you write point wise, not as a paragraph wise. Always draw, underline, draw pictures, make flow charts, create innovative answers rather than just bulking up your answer sheets, because you need to think about the way it was being evaluated. So always make the answers very presentable by underlining with red ink uh, and making boxes, making flow charts, or adding some pictures for like water purification. You can add pictures, so make it more innovative. So these innovations will definitely get you more marks. Sometimes if you are in a borderline, so these innovations will just cross you the borderline. So always try to write the answers in a more innovative way rather than just uh, bulking up paragraphs, because no answers will be read completely. They will be just glancing it. So if you find a point with underlined with reading, you will get the marks. So that was about the session 1. So I'll come with the next sessions. Thank you.